I'm sure, going to have people filtering in, which is just fine, but we'll get started here at 10:30. My name is Grace. I'm your moderator for today. Welcome to this session of the 2025 Culture of Data Conference. Thank you so much for being here. Rita Rochelle is our tech host. She's going to make sure all tech things are running smoothly, so if you're having any issues, please reach out to Rita. Everyone's muted right now, so if you have questions while Jessica is talking, please use the chat during that time, and then at the end, we will have 10 minutes for Q&A, and you can definitely unmute during that time. If you're comfortable, please add your pronouns to your name on your screen. You click the three buttons on the top right of your picture and hit rename, and then you can add your pronouns in there. We have one presentation today in this session. Should be about 25 minutes, but we'll see. And then we should have about 10 minutes at the end for questions. Please welcome our presenter, Jessica Wynn. Her work aligns closely with the conference theme by showcasing how data science and policy analysis can be leveraged to address key social determinants of health, specifically housing and nutrition within the Medicaid population, by using both qualitative and quantitative data to assess feasibility and inform the expansion of health-related social needs services. The study supports Colorado's efforts to promote health justice through more equitable and sustainable healthcare solutions. Jessica Wynn is here presenting Housing and Nutrition Services in Health First Colorado, Research to Support a Feasibility Study. Take it away, Jessica.
Can you hear me and see me? Okay. Good? Okay. Oh, sorry, getting situated. Okay. Sorry. We're gonna oh shoot. Sorry, I'm getting my screen situated. Oh, I'll just minimize that. Okay. Okay. So, hello everyone. My name is Jessica Wynn. I am the research analyst here at the Colorado Department of Healthcare Policy and Financing, also referred to as HCPOF or the department. I want to welcome you all to my presentation today titled Housing and Nutrition Services in Health First Colorado, Research to Support a Feasibility Study. So we start off our presentation with stating our mission, which is improving healthcare equity, access, and outcomes for the people we serve while saving Colorado money on healthcare and driving value for Colorado. So the department, we administers Health First Colorado, which is the Colorado's Medicaid program, the Child Health Plan Plus, CHIP, and other healthcare program for Coloradans who qualify. And digging into who I am and my team, like mentioned before, I'm a research analyst with the research and analysis team here at HCPOF. So we provide support to other teams and offices at the department. So it's providing a lot of internal support for these folks. And the work that we do may include things like program evaluation, data analysis, literature review, and researching other Medicaid agency for their coverage policies. So in addition to supporting internal teams here at the department, we also conducted some of the research for the feasibility study, which was required by legislature that mandated HCPOF to explore expanding housing and nutrition services. And so I'll be referencing feasibility study and these two bills a lot, and I will go more in depth in that a little later. But our team helps provide the research to help with the policy development of this work, and not the actual like policy development stuff, but it's the backbone to guide these policy development. And for the agenda, these are a quick overview of how we'll spend our time today. I will talk about the learning objectives, discuss how the vision and goals of HCPOF as it relates to health-related social needs, give an overview of the two feasibility studies, but primarily focusing on House Bill 1322, the Housing and Nutrition Services, and looking ahead. And so for our learning objectives, I have these two here. You can read it for yourself, but it's essentially understand the research and its impact on the department's health-related social needs feasibility study, as well as assessing the feasibility of adding HRSN services included in this legislation to the current Medicaid program. And so, what are HRSN? I want to level set that I understand that I'm speaking to folks that are currently doing work with the public health field or closely related to it. So, you all are engaged in this work in one way or another. So, I won't read this definition, but this is how we define it here at HICPUF. Um, and our vision for health related social needs are we are committed to covering programs that promote health and wellness. In addition, HICPUF is exploring opportunities to expand services and supports that address HRSN with the greatest impact on health. And this includes, but is not limited to, housing, food, transportation, and interpersonal violence. Excuse me. So we're still dedicated to doing this work at HICPUF because we are mandated by the state legislature. So regardless of what happened on the federal national landscape, we are still moving forward with this work. And so our goals for addressing health-related social needs are to understand and support member HRSN needs, improve short-term and long-term member health outcomes, and partner with the community to shape the future of HRSN service provided through the Medicaid and CHIP program. Okay, so I referenced the feasibility study in the previous slides, but essentially it's referring to these two legislation. So as mentioned, HICPUF was directed through legislation to investigate and expand health-related social needs. I see chat, but sorry. Okay, to investigate HRSN services that have the greatest impact on health and well-being based on the research. So in House Bill 24-1322, we were asked to study the feasibility of Medicaid covering a specific set of food and housing services for a defined population. So this legislation authorizes HICPUF to seek federal authority to expand certain housing and nutrition related services by July of 2025 if it's determined to be feasible. So whenever I reference or allude to federal authority, we're talking about the 1115 waiver. And so 1115 waiver in and of itself is a little more complex, but very simplifying it is that it is like one way the state Medicaid programs can pay for health-related social needs. So it's giving us the authority to allow us to waive some of the rules of Medicaid. So we have more flexibility. You can offer coverage to more people and expand certain services that typically wouldn't be covered by Medicaid. And then the other legislation that is related to health-related social needs is the House Bill 23-1300. So in this study, we were asked to look at a broader set of health-related social needs for a wider population and to expand on any research that wasn't completed in the previous feasibility study in 1322. So this one is a work that's ongoing right now that we will submit to the legislature in 2026. And the feasibility study around housing and nutrition have already been submitted in December 2024. So with all this, I think it's important to note that the timing of all this is a little interesting, funky, but we wanted to submit our 1115 waiver before the administration change, but also to recap, 1300 is looking at a broader set of HRSN, while 1322 is focusing on housing and nutrition specifically. For the House Bill 1322 feasibility study, so like diving into that piece, I wanted to share that there is a lot of HRSN related work that is already happening or currently underway at HICPUF. But today's focus is really focusing on the department's work as with HRSN as it relates to the feasibility study and our role in providing the research around these different housing and nutrition services for Medicaid members. Okay, so for 1322, again, focusing on expanding housing and nutrition, but why housing and food insecurity? Um, is like in direct response to the needs of our members. So as you can see on this on the slide, when we're talking about housing insecurity, for Coloradans with income under 200% of the FPL, 20% said they have problems paying their rent or mortgage. And for Coloradans with unstable housing, um, they are nearly 3 times as likely to report poor mental health as those with stable housing. And this statistics also rings true for physical health. And in regards to food insecurity, statewide, we see around 11% of Coloradans said they ate less than they thought they should because they couldn't afford food. And then among those incomes under 200% FPL, this figure was around 20%. And this is from CHI Colorado Health Access Survey, the third CHAS. Take a pause. Um, and so we are focusing on these two focus areas because we want to be responsive to the needs of our member. But there has been previous guidance from CMS on clarifying the role of Medicaid in addressing health-related social needs. So for the 1322 study, HICPUF was asked to study expanding housing and nutrition services, which includes exploring housing and nutrition services that could be covered under a 1115 waiver. And then we need to report the findings, and if determined feasible, then we have the authority to submit a HRSN amendment to the 1115 waiver. So feasibility, I've referenced to the feasibility of the study, but what does that actually mean? So feasibility has been assessed based on like different factors, which is seen on the slide here. First and foremost, we do need to meet CMS parameters. So identifying our target populations, provider types, addressing service settings, and so forth. We want to look at the implementation in Colorado as well as similar services that are implemented here in Colorado. So we want to look at how these services under consideration are either supplementing or integrating with the already existing infrastructure here in Colorado. So we look at the service at both the state and the local level. We want to look at implementation in other states. So when looking at other states, the services that we want to provide, have it been tried and tested elsewhere? And how successful were they in implementing it? And how impactful were they? We also want to look at the evidence. So this is like, what does the literature say around housing and nutrition services? And also looking at the costs and funding. So what funding sources are currently available and what are the costs necessary for the infrastructure investment? So for the feasibility, we're seeking this federal authorization to provide the services under consideration that we talked about in the study. We are looking at evidence that are both in support of and against housing nutrition services. So it included an extensive literature and landscape review. So for the first one is the review of existing services and infrastructure. So we hired a contractor, PCG, to support the coordination and collecting of information for for the work that's being done with other agency around Colorado. So we analyzed the data and existing services to understand what the potential impact would be for implementing these services under consideration. So other partner agency like Department of Human Services, Department of Local Affairs, and CDPHE are serving many of the through their respective agency program. And so as healthcare continues to move towards supporting the social needs of member, it gives us a really great opportunity to collaborate and learn from each other on how to ensure the needs of the members that we're serving are met. And so our team wasn't involved in this first aspect of the methodology. Um, so but it's primarily focused on these two pieces, the literature review and the other state research. So for the literature review, HICPUF conducted reviews on recent peer-reviewed journals around housing and nutrition services that were identified in House Bill 1322. So we focus on different factors like the cost, the healthcare utilization, and implementation factors for these services. And we also really lean into different organizations and entity who are experts in this line of work. So the Urban Institute and the Aspen Institute, respectively. And we also look at other states' research. Um, we looked at the approaches taken by states that just in supporting the HRSN work, but we also review their applications of their 1115 waivers and their implementation plan. And additionally, we also conducted informational interviews with other states that have implemented these services that are similar to what we are considering here in Colorado. So this was just mentioned in the previous slide. These are some of the factors that we were looking at when we were looking at some of these studies around housing and nutrition. So for the housing literature review, the housing services under consideration are generally supported by the peer review literature, and permanent supportive housing demonstrates a positive and substantial in housing stability and healthcare utilization. And just a quick definition of permanent supportive housing, PSH, it is an intervention that combines affordable housing assistance with voluntary support services to address the needs of chronically homeless people. And so we study these different housing services for two broad populations, individuals who are experiencing homelessness and individuals considered at risk of homelessness. And so PSH is widely supported, and the literature showed that there was a reduction in ED visits, increase in outpatient behavioral health utilization visits among PSH participants, and folks are more likely to fill their prescription once housed. And additionally, studies show that the participant often reported positive experience in improved health and well-being as a result of their permanent supportive housing. And we also look at the housing populations and the cost estimates for um, we try to calculate the housing population and cost estimates for these services. One thing for folks if you're familiar with the feasibility study, the cost estimates was something that we were not able to get to in this feasibility study, but we were hoping that we will get to in the 1300. So initially, we are able to provide the housing population estimate, which is looking at the individuals experiencing homelessness statewide, and that data is pulled through Colorado Homeless Management Information System. Um, and we also looked at households that were at risk of being homeless based on their incomes and being cost burdened by using 50% or more of the income on housing. And so, taking into consideration these two populations, we came up with a rough estimate around 200,000 members would fall within the eligible populations that we define in 1322. And then again, the costs would be something we will focus on in the upcoming work. And the literature review, we also conducted for nutrition services as well and provided cost estimates for medically tailored meals and produce prescriptions. So for the nutrition literature review, we found that nutrition interventions have emerged as an important strategy in addressing the diet-related health conditions and food insecurity among vulnerable populations. And also the field of nutrition research is growing with more robust studies being conducted. And this is a lot is referencing food as medicine, food as medicine. But based on the literature, it was shown that medically tailored meals and produce prescription can help reduce the healthcare costs and healthcare utilization associated with food insecurity. Medically tailored meal also can improve health outcomes and reduce um, admission rates and ED visits as well. Produce prescription, on the other hand, have found to increase fruits and veggies intake, decrease food insecurity. It also improves hemoglobin A1C level as well as blood pressure and BMI. So overall, there's a lot of promising results that I think be very helpful in guiding our work moving forward as it relates to nutrition services. And for the nutrition population cost estimates, how we came upon how we approach estimating the cost for medically tailored meal and produce prescription is that we look at different factors when calculating um, when we looked at different factors to figure out how to calculate for this cost estimate. So first we looked at the number of adult members with qualifying diagnosis. So we look at claims data for different diet-related health conditions that were identified in literature. And so some of these conditions were type 2 diabetes, COPD, um, uh, and stage renal disease. So just like in addition to other type of diet-related health conditions. And so we came up with around 270,000 individuals would be eligible for uh, medically tailored meal and prescription boxes based on their diagnosis. And then we looked at the social risk factor, which is utilizing 20% of Medicaid members being food insecure. And this number was also, again, pulled from Chad's food security question. And so we came up with around 50,000 individuals that will qualify based on conditions, qualified condition, and food insecurity risk factor. And then the costs per member per meal, we have this information available based on our home and community-based services, medically tailored meal work. And so we have that number to use for the calculation. And for the produce prescription, we use the number that often came up in literature. And taking into account all these factors, we calculated the highest dollar amount, assuming 100% uptake, and providing these services for over a 6-month span. And so we came out with the cost projection for 3 medically tailored meals per day and produce prescription for qualified members, as well as providing 2 meals per day and produce prescription for qualified members for 6 months. Let's see. And then for the other component of our team's work was researching other states' 1115 HRSN work. And so we reached out to other states that were a little further along in their HRSN framework and 1115 work to glean some learnings from these states. So we interviewed Massachusetts, New Jersey, North Carolina, Oregon, and Washington. And these interviews were with staff members who were real heavily involved in their 1115 waiver submission. So these are some of the topics that were covered. So we um, asked around, asked about their housing and nutrition providers and discussing eligible populations, the screening referral methods, the data sharing, provider enrollment, and the questions and system questions. So that's around like the reimbursement and what their rollout process looks like. So some key takeaway from those conversations was that first that phased rollout for HRSN services is common and 6 months minimum to start after approval is granted. And so what this means is that the majority of states are actually implementing whether it be housing first or nutrition services first. One of these services area will be rolled out first and the other will be um, rolled out at a later date. And we saw this in all the states that we interview. The other is consider the rollout plan of services as early as possible. Before even waiver submission, I think it's important to have these conversations with other state agencies and be in alignment with the work, but also building those relationships with community members and CBOs that are doing this work around housing and nutrition services and building these relationships. And lastly is overlapping authorities for HRSN services should be considered early. Okay. Okay. So how does this all tie in and how is it like related to the 1115 waiver? So this is a oversimplification of the timeline. Um, and so in August 2024, so in August of last year, we submitted an amendment to the 1115 waiver to add housing and nutrition support services. And then in January of, oh, sorry. Yeah, so the HRSN amendment was submitted August, And in January of this year, CMS approved our 1115 amendment for the health-related social needs. And so this amendment goes live July of this year. And so, okay, so this is just a repeat of what I just mentioned. But so our authority will begin on July 1st of 2025, and housing work will be implemented first with the nutrition services to roll out at a later date. Um, and so this goes in alignment with other states that have been doing this work as well, where one services is provided first with the other one to follow. And then lastly, we like I touched on before, the House Bill 23-1300 feasibility study is currently underway, is happening right now as we speak, where we are expanding the HRSN services and populations that we want to, um, expanding health-related social needs services and populations. We're also going to look at components of 1322 that we didn't get to before. So that will include um, estimating the cost of housing services as well. Uh, and we do have an upcoming webinar happening next month. The link is here, but also in the chat, I think. So we are going to provide an update to our 1115 waiver. It's called Comprehensive Care for Colorado. There's a slight name change to be more encompassing of the work that we're doing. But it will be a informational with a Q&A session that will be discussing housing and nutrition services for substance use disorder, as well as for those leaving incarceration from a state facility. There will be staff that will provide updates and answer your questions. Then, yeah, I'm almost to the end. Okay, ways to engage. So I think the best way to engage is to sign up for our email newsletter. You can also scan this QR code, which is the same as the link. But it is the best way to be informed of current happenings as it relates to HRSN and 1115 work. HICPUF is looking to engage with individuals and organizations who are impacted by these efforts and these expansion of services to these populations. And so we value feedback. There's going to be stakeholder opportunities as well. And so, yes, the best way would be to sign up for the newsletter. I think this is question, contact information. Yeah, I think that's out of mine.
Thank you, Jessica. And now this is our Q&A time, so folks feel free to unmute and ask a question. If you're not comfortable unmuting, please throw it in the chat and I will make sure to read it out loud.
Hey, Jessica, thank you so much. That was such an incredible presentation. It's so interesting to hear about that. I have a few questions. The first thing I wanted to ask you was about looking at the other states that you had. Did you see, so it sounded like there were a lot on either of the coasts. In your analysis, did it seem like there were some states that were more similar to Colorado and how they operate, and others that are different?
Yeah, so the states that we reached out to were states that were looking at services that we were also looking into as well, and so that's why we identify those. I would say Washington and Massachusetts are most like us when we're talking about our housing services. And as for in housing, and so yeah, so the states that we identified did align with the services as well as like where they're at in their progress, and so they all have submitted in or been approved for the HRSN and 1115 waivers, and so that's why we reached out to hopefully gather like best practices when we submit our own waiver.
Gotcha. Cool. And I'm also curious about, you touched a little bit on the nutrition services. I think I'm not as familiar. Like, I feel like there are so many different kinds. Like, is the nutrition services that you were looking at for this feasibility study, was it about like cost of nutrition that you were dealing with, or was it like access to nutrition, like food deserts, or was it were you examining kind of like the sort of education and counseling type things related to nutrition?
So yeah, there's it defined services that was services for nutrition that was included in the legislation. So that was like the medically tailored meal, the produce prescriptions, and pantry stocking. Pantry stocking was one of the areas that we didn't get to in the study. Including the cost estimate of it, but the medically tailored meals and the produce prescriptions are two of the ones that we focused on. Understanding that nutrition counseling and education is, in most of these studies, have been like a component, an add-on component. It's not like a standalone area of work. And so like those were the ones we focused on, and is looking at the what infrastructure is currently already exists. And so Colorado Medicaid, we currently do pay for home delivered meals, but not produce prescription or pantry stocking. And so, like, what could it look like? And if we were to implement it, what would the cost be? What organizations are out there that could be in alignment that we could partner up that might be expanding our potential Medicaid providers?
I have another question. You showed us the timeline there. You said it was simplified. I imagine, yeah, there's lots of nuances to it. Would you say that that is a typical timeline from like, interest in feasibility study to boots on the ground policy implementation and you're seeing it happen? That's the first part of the question. And the second part of the question would be, how do you think that will be affected by the current political climate, the current administration, and sort of how that's touching lots of public health things?
Yeah. I might need a reminder for the questions, but to answer, so the first question is this a typical timeline for this type of work? I would say yes and no. And for that is that legislation sometimes pass through very quickly where we need to be responsive and provide the work that's asked of the legislation. So I would say that in that regards, yes. Um, but the other component of like us submitting our waiver and the turnaround time for this legislation study, it was expedited. And if you really sat down and look at the timeline of all the tiny components that we worked on, you will realize it is wonky because we realized that with the administration change, like we wanted to submit a waiver before any disruption happened. And also typically with administration change, there is a change in priorities as well. And so Colorado, along with other states, we really wanted to push that waiver through. And so, yeah, so I would say somewhat aligned with typical timelines, but also not really. And the other, oh, I already forgot what's your second question?
That's okay. um, my second question was, do you anticipate, I mean, your timeline was already affected by changing administration because you sort of expedited the first part. Do you anticipate seeing, um, I would assume, sort of a lengthening of the rest of the timeline because of the public health impact we've seen so far? Um, or what would you think that might look like? And I know that, we don't know a whole lot yet, but have you seen
Yeah,
it already?
yeah, so yeah, like you said, and like many other folks at the conference have said, like we don't have a crystal ball to predict the future of Medicaid cuts and spending and what the federal landscape would mean for public health. But for the timeline of the work that we're involved in, more specifically the feasibility study, so the 1322, the housing nutrition work has already been submitted. So we didn't take into consideration the national landscape, but for the upcoming feasibility study, the 1300, that is looking at a broader set of health-related social needs. We are taking into consideration going through the different scenarios of like what services might have a more pushback and whatnot. So that is something that is more that is a consideration of our current area of work.
Awesome. Thank you.
Thinking back to the other state recommendations, one of the ones that you mentioned was the advice that of the need to consider overlapping authorities for HSRN services. Can you tell me a little bit more about what do you mean by that? What is the sort of need to sort of do that early?
Yeah, so for example, for like nutrition, we want to make sure that the programs that are administered at the state and federal levels, like the SNAP and the WIC, that there is like no duplication, just in regards to like federal matching purposes and whatnot. So speaking particularly to like the nutrition piece, states are required to outline how they're planning to partner with other agencies. And so CDPHE is like administering various nutrition programs. And if we were to consider medically tailored meals, produce prescription, pantry stocking, if there's any overlap, how does the funding get impacted? And so that's just more of like, make sure we're not duplicating efforts and how can we better collaborate to make sure the resources are um, yeah, being put in the right spot, right areas. Yeah.
I see. That can be super challenging from like the sort of infrastructure side to try and follow folks or sort of map out that duplication. Do you know how does that are there efforts to sort of ensure that like the systems are able to sort of work together in that way for HICBUF?
Yeah, I think that's a great question. Also, there are folks that are in this leadership roles that are really in like conversation with other agency that there's like routine conversations with like DOLA, CDPG, uh, CDHS, and so these conversations do exist. And it's just make sure the right folks are at the table, and making sure whenever these services do get rolled out that we are in alignment. So.
Cool, gotcha. Well, on that note, I mean, that's also making me think about, so I work for a Department of Public Safety, and we do some stuff for domestic violence and sex offender management. You mentioned at the very beginning that some of the factors that are involved in health services include interpersonal violence, which is super interesting. And I know this was mostly about housing and nutrition, but it sounds like you guys are looking to expand to some of those additional factors. So I'm super like, so what are the ways that you're hoping in this upcoming study to sort of examine interpersonal violence if you're looking at that very much there?
Yeah, so I won't be able to speak as much to it because I'm not involved in the current area of work, but interpersonal violence along with it, like climate is like other areas of HRSN because housing and nutrition, lots of work that's already happening, lots of evidence that is there. We do hope to expand to other HRSN service. What that would include and what that would look like is that's what we're hoping to do this year. Research will continue to happen. We will reach out to community members and community organizations to seek their feedback. But yeah, it's ongoing. We're really excited to see where the work takes us, and looking to other states that may have already done this work already or is starting to do this work. So we're leaning to those states as well.
I just wanted to add something if you're interested. North Carolina right now is like the leading state for addressing interpersonal violence through Medicaid and their 1115 waiver. So if you're interested, you could always look into what they're doing. It is really interesting. But yeah, like Jessica said, we're currently like in the process of narrowing our own scope for the 1300 study.
Yeah.
Oh, gotcha. Very cool. Well, go North Carolina. That's good to know. Um, yeah, the H 1115 waiver is super interesting. You can do all of these cool things with Medicaid for those sort of services. Are there?
Within
I'm not.
limitations. Yes.
That's what I was going to ask. Is what kind of limit, or like, is there also like, do you have like required data tracking and stuff like that, or what does that sort of look like?
So yeah, CMS has a lot of information around 1115 waivers and how it works. One of the not the caveat, one of the things when we're looking at 1115 waiver is that the additional reporting that needs to occur, data tracking that needs to occur, because these are typically either like innovative changes or you're expanding to expanding services or populations that are typically not covered by Medicaid. You want to track the progress and the impact of the work that is being implemented. So it does require additional evaluation and data reporting. So that's like one of the things that 1115 requirements of the 1115.
Awesome. All right. So I don't see any questions in the chat. Um, so I think we will move on to our final announcements here. Thank you so much, Jessica. That was lovely. And Colette from the chat, keeping us up to date with all of these links. That's super helpful also. Um, Thank you everyone for being here today and for attending and for choosing to spend your morning with us. The slides and handouts from Jessica and her colleagues will be available on Sketch, so please look there if you're looking for those. The QR code on the screen is for our conference evaluation. Please do the evaluation, even if this is the only 45 minutes you spent with this conference. Your thoughts are valuable. We use the information. We made changes this year based on the feedback from last year, and it's extremely valuable. So grab this QR code. Otherwise, we will also be sending you the link in your email when the conference is over. Next, we have a break for lunch. The next session starts at 12:30. It's a poster session. That's new this year. So even if you're just curious what a virtual poster session looks like, come check it out. There are 5 demonstrations of new research and real-world applications of data in tackling social determinants of health. The poster sessions will be interactive and they showcase innovative projects that use data to expose inequities and drive actionable change in public health. They're going to be happening concurrently in different break rooms. So during that full 45 minutes, you can sort of pop in and out of each poster and check out as many as you like. Sketch has the full details of all the posters, so you can go in there and pick which ones you'd like to visit. Thanks again, everyone. Thank you so much, Jessica, for sharing your work with us. Have a good one.
Okay.